Hello, and welcome to today's AAPS webinar. Thank you for joining us. Before we get started, I'd like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. On the right-hand side of your screen, you will see the Q&A and polling window. There's a large window which holds all of your sent messages and a smaller text box at the top where you will type in your questions. To send a question, click in the text box and type your text. When finished, click the Send button. Questions will be addressed at the end of the presentation. I would now like to turn the microphone over to our moderator for opening remarks. The floor is yours.
Good morning and good afternoon. I'm Chris Boyce from the Merck Research Laboratories. Today's webinar is sponsored by the AAPS Global Health Community, and I'm co-hosting today with Professor Pramod Mahajan from Drake University. Our speaker today is Dr. Peter Kilmarx, MD, who is Acting Director of the Fogarty International Center and Acting Associate Director for International Research at NIH. Dr. Kilmarx is an expert on infectious disease research and HIV/AIDS prevention. During his tenure at Fogarty, he has led analysis of NIH global health activities, built coalitions with high-level NIH and external stakeholders, and represented the center and NIH in national and international forums. He co-leads an initiative to transform African health professional education and research, resulting in the formation of the African Association for Health Professions Education and Research, as well as the African Postdoctoral Training Initiative, which brings African postdocs fellows to NIH. He has focused his efforts to increase equity in global health research and build global capacity for pandemic preparedness. Dr. Kilmarx previously served as the CDC country director in Zimbabwe, providing oversight for 30 staff who managed implementation of the U.S. efforts to reduce HIV/AIDS, TB, and malaria. A Rear Admiral and Assistant Surgeon General of the U.S. Public Health Service, Dr. Kilmarx served as the CDC Ebola response team leader in Sierra Leone in September to October 2014, and as Principal Deputy Team Director in Guinea in January to February 2015. Previously, he initiated the CDC response to the Ebola outbreak in the Democratic Republic of Congo in 2007 and led household surveillance in the Ebola outbreak in DRC in 1995. The title of today's webinar is Global Health Research Opportunities and Priorities, Perspectives from the NIH Fogarty International Center. The floor is yours, Dr. Kilmarx.
Well, thank you, Chris, and hello, everyone. I'm delighted to have this chance to talk to you. It's really want to share the message that NIH is very strongly supportive of global health research collaborations and definitely engaging and would love to engage further with pharmaceutical scientists. I've got about 25 slides, so I'll take half an hour or so to go through them, and then I'm happy to answer any questions or expand on anything that I've talked about. So first, just so we're starting at the same place, is just to make sure everyone's aware of the mission of NIH. It's the largest funder of health and biomedical research in the world. And the mission is really twofold. The first part is about the basic science, the fundamental knowledge about the nature and behavior of living systems. And then the second part is about the application of that knowledge to extend healthy life and reduce illness and disability. There are 27 different institutes and centers at the NIH. I think most of you are aware of some of the bigger ones, the National Cancer Institute, the National Institute of Allergy and Infectious Diseases, but pretty much by disease or organ system or population group, there's an institute or center at NIH, and I'll talk a little bit more about some of them in a minute. And it's also important to understand the dual nature of NIH. A small part, relatively small part of the funding, about 11% of the budget, is for the intramural research, 6,000 or so scientists that are at the NIH. And then most of the funding, about 81% of the budget overall, is for extramural research. And this is what supports the research and training of scientists really in the US and all around the world. Over 2,000 institutions, over 400,000 scientists, about 80,000 applications and about 45,000 awards, grants from NIH annually. And this is just a look by institute and center at the budget. The overall budget for NIH is $46 billion, again, which makes it the biggest funder of health and biomedical research in the world. The kind of billionaires club, and these are, this y-axis is in billions, NCI, NIAID, aging, heart, lung, and blood, general medical sciences. You can see actually Fogarty is here we have the lowest amount of funding. These are billions of dollars, so that's $95 million for Fogarty. And the nature of our work in fostering international partnerships, we actually have the highest amount on a percentage basis of co-funding from the other institutes and centers. So this slide is about why we pursue global health research. And just to start at the top is because of the unique populations and disease presentations, and especially genetics. Unique genetic populations around the world is a very strong rationale. There's unusual exposures and environmental conditions around the world. Infections, especially infectious diseases, if we want to learn about, develop vaccines and treatments for Ebola, for example, we need to do that in West Africa or in Africa where it's prevalent, and you can't wait until it comes to the US to do something like that. There's unique interventions, especially some frugal or novel technologies and health technologies that we develop through international collaboration. There's the insights and expertise of a diverse set of investigators. The best scientists and brains aren't all in the US, they're all over the world, and we benefit definitely from collaborating with them. There's large and potentially treatment-naive patient populations. This is important for clinical trials. If a study wants the participants to be treatment-naive, or for rare diseases. By nature, there's a lot of people have rare diseases, but for any one disease, it's often necessary to have global collaboration and cohorts to be able to have the numbers to do a sufficiently powered study. There's alternative health systems that we can learn from around the world. And then I think, as many of you are aware, there's just a lot of interest in early career researchers, trainees, healthcare providers in global health. It's really a great interest in the next generation. And then lastly, we just need new tools to reach our global health goals, whether it's control of HIV or malaria or diabetes or Alzheimer's. We need to always continually need to have research and new tools to reach these goals. Just taking a look at this image on the right, I used the program DALL-E, like Salvador Dali, and I was giving a talk for vision researchers in Mexico, and one of the sessions was about aflatoxin. And so I asked DALL-E to make an image with eye research with indigenous populations in DNA and corn in a Mexican painting style. And this is one of the images that it generated through artificial intelligence. So I just want to reflect on, I don't think, well, it's been said that artificial intelligence probably isn't going to take your job, but someone who can use and understands artificial intelligence might. So I just wanted to highlight this creative use of AI. So one example that we'd like to share is work that's been done in Colombia, in South America. This is with a large family cohort, thousands of members of this family that has an autosomal dominant form of Alzheimer's disease. And it was with support from Fogarty that this family cohort was fully characterized. And people who have this gene in this family will inevitably develop Alzheimer's, usually in their 40s at a relatively young age. So you can imagine if you want to do a clinical trial of a prevention or treatment or if you want to identify biomarkers, you can do that kind of a study with hundreds of people over a few years if you know that they've got this gene. And by contrast, in an undifferentiated population in the US, it might need thousands of participants in a decade to be able to get that information. So this is just one example of the advantages of global collaboration. A few years ago, with Josh Grubbs, who was at the time was a postbac and is now graduated from medical school and in an internal medicine residency, we asked the question: what percentage of publications funded by NIH have a non-U.S. affiliated co-author? We really wanted to assess to what extent NIH funding fosters global collaboration. We thought it would be 10 or 20%. What we found is that 35% of all NIH-funded publications had a non-U.S. affiliated co-author. So it really is a global enterprise. And we looked, that second bullet there, those publications that had both U.S. and non-U.S. affiliated co-authors had a greater mean citation impact score, so a greater scientific impact by one measurement, compared to the papers that had U.S. authors only or non-U.S. authors only. And you can see on the left side the countries with the greatest numbers of these co-authors or publications with co-authors from their country. It was actually China that was number one, coming up from number 4 over the course of a decade. And the others are high-income countries, the UK, Canada, and Germany. And then you can see on the right side figure, excluding China, the other low and middle-income countries that have the greatest amount of collaboration: Brazil, India, South Africa, and Mexico. So just to underscore that NIH's work is really global. One tool, if you're interested, is that you should be aware of, is called worldreport.nih.gov. This maps the funding from NIH plus over a dozen other major funding agencies, the Wellcome Trust, the Bill and Melinda Gates Foundation, the UK MRC, and others. So this is a way to find exactly who and where is being funded, including the subawards and indirect funding. Over 15,000 research institutions, over 500,000 program records, and just a few examples there on the right. If you're looking, where is One Health being funded, or malaria, or cysticercosis, you can enter that as keywords and see where the funding is. So if you're interested in a particular region or country or disease area, this is a way to find who's doing what where and potential collaborators. So with that data, just looking at where NIH is funding international collaborations and research, this figure shows the number of foreign records in World Report, NIH-funded records by country. This is the countries with 100 or more records, which represents 88% of all the records are in these 38 countries. And you can see, again, the top ones are high-income countries: Canada, UK, Germany, Australia. But you can also see there's a number of middle-income countries and even low-income countries. For the low-income, Uganda, Malawi, Ethiopia are in this top group with more than 100 collaborations funded by the NIH. So that's just one way of looking at this international work by NIH. And then just the same information put into a map, a heat map, and again, it's Canada and Western Europe, with a lot of the international funding support from the NIH. And then, so now looking at the same information, but looking at it by NIH Institute and Center. So there's a total of 19,000, nearly 20,000 records of foreign collaborations funded by the NIH. And you can see, not surprisingly, the largest, the biggest is NIAID, so infectious diseases, followed by NCI, cancer, general medical sciences, heart, lung, and blood, neurologic diseases and stroke, mental health, aging, etc. But an important point to make here, there's 24 institutes and centers at NIH that have extramural funding, and they're all here. Every grant-making NIH institute and center supports global health research. So if you're thinking about global health, getting funding for global health research and collaboration or training, yes, infectious diseases and cancer, but it's really quite diverse. Even dental research and nursing research, they're actually have approached us recently and are particularly interested in, they have global collaborations, but interested in expanding their global portfolios. So now coming to the Fogarty International Center, this is our, we just celebrated our 55th anniversary. It was Rhode Island Congressman John Fogarty, who was a big champion of NIH and of global collaboration, was the namesake for the center. And we support all of the NIH in their global partnerships and interactions. And then with our own resources, we focus on training and capacity building in lower income countries. So our strategic goals from Fogarty is really building the capacity of individuals, institutions, and networks, looking at those multiple levels for capacity building. We support research. We want to stimulate innovation in development and evaluation of new technologies. We have a special focus on research and research training and implementation science, and really shortening the time from when intervention is shown to be effective to when it actually goes out into the clinic or in public health policy to be implemented, and the science of that process. We include both communicable and non-communicable diseases, infectious disease and NCD in what we support. And it's increasingly obvious to me the importance of the partnerships, and how when we have these global health emergencies or want to conduct some research, how important having that longer term partnership is to be able to be effective. And this is just a schematic of how we provide training and career support. We've really learned over decades of doing this from Fogarty that to develop real leaders around the world, which we've been quite successful at, we want people to be well trained. They need to have protected time to conduct research in the low and middle income country, which is often a challenge, and our funding provides that opportunity. And then they need strong support, mentorship, both from a U.S. investigator who's experienced working in that context, and from an investigator who's actually from that low and middle income country. So starting at the left with undergraduates and going through to a career, above the schematic there, the figure there is our career in training award. So we have research training programs that are quite diverse. We have a Global Health Fellows and Scholars program, which provides funding for individuals to spend a year in a low and middle income country. Either some of them are in their doctoral training, some are postdocs. And then we have the ERSTA, the K01. This is for U.S. investigators to have 5-year funded career support. With the Fogarty K, they are required to spend at least half of their research time living and working in the low and middle income country environment. And then the second there, the K43, this is unique at NIH. We started it in 2015. This is for researchers from low and middle income countries, giving them 5 years of career support to pursue their research and career development in their low and middle income country, in their home country. And then at the bottom are the NIH research grants. And Fogarty's, most of our funding goes to the training and capacity building. And so most people with Fogarty training then kind of graduate or move on in their research career to get those research awards from the other NIH institutes and centers. And so over the years, we've trained more than 7,000 scientists worldwide, many of whom are in real leadership positions at WHO in their national ministries of health or research institutions. We, at any time, we support over 500 research and training projects with collaborations with more than 100 academic institutions in the US and around the world. And it is quite diverse. It's infectious diseases and One Health and chronic conditions and NCD, but also informatics, mHealth, bioethics, implementation science, brain disorders, mental health, tobacco cessation. Climate change is really a growing area. There's significant new funding on climate change and health at the NIH. I'm on the executive committee for that NIH program. One of our Fogarty staff is the co-chair of the steering committee for that work. So there's a strong recognition at NIH that climate change and health is a global issue, and we're quite involved from Fogarty in the implementation of this program. Just to give some examples of the kinds of things that we support that are relevant to you, here's a program led by Charles Maponga in Zimbabwe and Jean Morse from University at Buffalo. This is on HIV clinical pharmacology and therapeutics research. It's a training program in Zimbabwe. It's looking at some of the new and emerging technologies for HIV treatment and prevention, and training Zimbabweans on looking at the optimal pharmacokinetic and pharmacodynamic parameters to sustain successful treatment, viral load suppression, drug safety, and with that viral load suppression, reducing HIV transmission. So now with the use of tenofovir, lamivudine, and dolutegravir, which has really become standard treatment in many of these countries, a single tablet once a day. There's now use of long-acting antiretrovirals such as cabotegravir. There's new antiretrovirals being developed, and then use of broadly neutralizing antibodies. So this program is research training around the use of these new therapeutics, and specifically is for the training of pre-docs and post-docs, for mentoring and team science, fostering community support, group engagement, and fostering academic public-private partnerships. So that's just one of our many research training programs that I thought would be of interest to this audience. One of our trainees, we had something called the Medical Education Partnership Junior Faculty Program. One of the fellows, Dr. Ilo Mwanya from Nigeria. She's a pharmacist, biomedical engineer, and lecturer, and is developing a palm oil-based gel for topical HIV prophylaxis, a topical microbicide that she's been developing with a goal that is something that women could apply before having sex that would prevent male to female and also female to male HIV transmission. So I had a lot of examples when looking for things of interest to pharmaceutical researchers, and I'm not going to go through all of these in detail, but just to give you a sense of the diversity, the scientific areas, the geographic diversity, looking at trypanosomiasis in Nigeria, looking at development of botanicals for chronic disease treatment in Tajikistan, in Indonesia, looking at CXCR4 and CXCR7 agonists from traditional phytopharmaceuticals for treatment of mental disorders in Peru, looking at methotrexate for treatment of Burkitt lymphoma in Malawi, treatment of tuberculous meningitis in South Africa, and looking at pharmacoepidemiology for predictors of low-level viremia in Nigeria. So it's really quite a diversity of research areas and partner institutions, investigators, and countries where that work is being done. Just one other area of interest to highlight, this is Dr. Joel Bremen, who's a Fogarty Senior Scientist Emeritus. He had a real lead in this activity a few years ago, looking at the pandemic of falsified and substandard drugs, which I assume many of you are aware of, but they've really highlighted the fact that these falsified and substandard medicines are associated with tens of thousands of annual deaths, mainly in young children in poor countries. Ineffective antimalarials is a lot of this. The costs are over about $200 billion per year. And that in addition, is just the cost of increasing antimicrobial resistance as a result of use of substandard medicines. And the World Health Organization really divides this into three categories. There's the falsified products that are really criminally, deliberately misrepresented and distributed. Then secondly, there's substandard medical products where the intent is to develop a pharmaceutical product or medical product and it just fails to meet quality standards. And then there's very widespread unregistered or unlicensed medical products that haven't been properly assessed or approved by any stringent regulatory agency. So this is a important area where Fogarty's been involved in some of the work. And I also thought it would be of interest to this group. There's a couple of courses from the NIH Office of Clinical Research Education and Collaboration Outreach. These are online training courses that very popular, very well developed, very high quality. On the left is about principles of clinical pharmacology, and the link is there. We can share these slides, or it's easy enough to find this link. But this has been, again, a very popular course on clinical pharmacology. And then on the right, the other that's even more popular is Introduction to Principles and Practice of Clinical Research. So these are quite extensive with 40, 48 lectures. It's possible to get a certificate of completion following along and completing the lectures and getting a good score on the final exam. So I thought this would also be of interest to this audience. And just broadly, in terms of our interests in global health coming from Fogarty and from NIH more generally, this is a paper that we wrote a couple of years ago. This is with Dr. Glass, who was the director of Fogarty and is now retired. But we really came back to, after the COVID-19 or through the COVID-19 pandemic, really underscored the importance of having that health research capacity around the world as an essential element of pandemic preparedness, something we're still very much focused on, and that building health research capacity, which is our main mission, really needs to be a high priority to achieve our global goals and to be resilient to future health threats, whether it's another pandemic or climate change issues, mental health, aging, all of these multiple threats. That having that capacity in the countries where the work is being done is so important. And then the second bullet here is about something I'll say a little bit more about. Is really, we saw that some of the lower income countries were really actually quite effective in their public health and quite science-based in their approaches. So we think we should really bring a new sense of humility and equity in understanding the lessons of COVID-19 in our collaborations and partnerships going forward. So some of the particular areas from the same publication is at that time really focusing on the research response to COVID-19, where we had home rapid self-tests, vaccines, but really an unfinished agenda, including that's ongoing with long COVID. So this is a key area for research, a priority for global health research going forward. But the others, really long-standing issues. If you look at what's been the biggest increase in disability-adjusted life years lost over the last few decades, it's really been in non-communicable diseases, chronic diseases, heart disease, diabetes, stroke, kidney disease, cancer. And these have overlapping risk factors. So hypertension or high fasting plasma glucose, air pollution really emerging as a key risk factor for multiple diseases. This is going to be a very important area for global health research for years to come. That second bullet there is a large area of One Health that includes the pandemic preparedness, infectious diseases, and also antimicrobial resistance, but really better understanding this interconnections between humans, animals, plants, and the environment in a transdisciplinary approach is the One Health approach to these issues. Planetary health, another very broad area looking at the health impacts of climate change, but of also declining biodiversity and increasing pollution and shortages of natural resources. And then lastly, from our perspective, implementation research as a key area in really promoting the uptake of these interventions into routine healthcare and public health settings. So just in terms of what our priorities are there, we've spelled them out. And again, on the equity issue, there's been a lot being written and said about decolonizing global health from NIH. We speak about it in terms of promoting equity in global health research. So there's 8 NIH institutes and centers that we're working with Fogarty and 7 others that we're working with, the ones with the biggest portfolios in global health. And we had a request for information about this topic on promoting equity in our global health research partnerships. We had over 180 responses, which is considered quite a robust response, and identified some key themes in from these responses to our request for information about inequity in research partnerships, about some of the funding limitations and funding structures, about the capacity issues, who sets the priority for research. Often we'll fund a U.S. investigator and they'll approach an investigator in a low-income country and say, hey, I've got this funding to study this disease. Do you want to partner with me or not? And that's very different from the low-income country researcher actually developing the research question and research agenda and getting the funding, and then could partner with the U.S. researcher. So that dynamic is a critical theme. Who owns the data and has access to the data has been very important. And then just at NIH, having the representation in the peer review, people actually evaluating the funding applications and making the decisions is very important. So we've got these results from this RFI, and we're now working with this NIH working group to go forward with action items about further promoting equity in our partnerships. And we looked last year, this is with Esene Akudinobi, who is an MPH grad who worked with us for a couple of years. One of the metrics of equity is actually who is the author, the first author and the last author on the publications. And it's been noted that the African authors are often stuck in the middle, that the first author and the last author will be from the US or a high-income country, and the Africans are stuck in the middle. So we looked over a period over a decade at the papers funded by Fogarty that were about sub-Saharan Africa. It had sub-Saharan Africa as a one of the mesh topics. And what we saw is that the first authors who had a sub-Saharan Africa affiliation increased from less than half, 47%, to 63% by 2020. The last authors also increased, but still fewer than half of the last authors had a sub-Saharan African affiliation. Also, that the relative citation value for the publications by the sub-Saharan African authors was lower than the citation score for the papers that had U.S. affiliated authors, so still some inequity there. So we thought this reflected on an increase in equity, but still needed additional investigation and actions to try to have a more equitable relationship between our grantees from Fogarty working in sub-Saharan Africa. So let me wrap things up. Again, in summary, that there's very strong support from NIH for global research and global research collaborations. It's very diverse. It's all over the world. It's all regions. It's all research areas, not just infectious diseases. There's very strong support from Fogarty for the training and capacity building as our primary focus. And we really see the research capacity strengthening in partnerships as the keys to global health resilience and addressing the global health threats, you could say, but we see them as research opportunities. Let me encourage you, if you're interested, to subscribe to our newsletter. We have a funding newsletter that comes out every week, and it highlights the funding opportunities from NIH, but also from other U.S. partners and really any funding from the private sector, from other countries that would be of interest to global health researchers comes out in that newsletter. We also have a Global Health Matters newsletter that comes out 6 times a year that you can also subscribe to. And then we're on social media, which is a good way to keep in touch with news from Fogarty and about global health from the NIH. So it's been great to have this chance to talk to you. And now plenty of time and very open to any questions or further discussion that you want to have. Thanks.
Thank you, Dr. Kilmarx. That was a wonderful overview of efforts at Fogarty. I'll hand it over now to Pramod for questions.
Thank you, Chris. And again, thank you, Dr. Kilmarx, for the elaborate presentation and information about the Fogarty International Center's opportunities. We have several questions here. I'm going to read those to you one by one. I might slip one of my own in between also, just taking advantage of my position here. But let me first go to a question that was asked by one of our attendees. And the question goes, I have learned that Africa has the greatest genetic diversity than any other geographic location. Does that inform the granting approach at Fogarty?
Yes, very much so, and a very important observation. Obviously, humans have been in Africa for a lot longer, over 100,000 years, and then traveled from there to the rest of the world in the subsequent tens of thousands of years. So, looking, just the diversity within Africa is often greater than among other populations around the world. So let me think now, at least 15 years ago, NIH, the Common Fund, which is NIH-wide funding mechanism, the NIH Common Fund, together with the Wellcome Trust, developed what's called H3 Africa, Human Heredity and Health in Africa, and provided direct funding to African genomics researchers with dozens of research centers around Africa, and have sequenced tens of thousands of human genomes in Africa, and really been quite productive in really further characterizing African genomics, and really looking forward to applications, having chips with the really appropriate African genomes for further research, doing the pharmacogenetics of looking at differences in treatment that we see in African populations versus in mostly the work had been done in U.S. or high-income country Western populations. So really important to develop that. And now we have another Common Fund program, Data Science and Innovation in Africa, again, direct funding to African research centers and research sites. And a lot of that data science and innovation is around the genomics and genomic science. There's particular interest in sickle cell, developing further characterizing and treating sickle cell disease in Africa. But it's the Human Genome Institute, but Fogarty and Cancer and many of the NIH institutes are very interested and supportive of genomic research in Africa. So thanks for the question.
Thank you. I believe you have already kind of answered this question, but maybe this will be another opportunity for you to reemphasize that. The question goes, does Fogarty and or other NIH agencies have a way to track the quality of the collaboration so that the low middle income country investigators are involved in the scientific work rather than treated as a source of samples?
Yes. So the sort of beginning of that is that bibliometric analysis and looking at actually who are the first and last authors.
Right.
So that's kind of a basic way of doing it. But we're also this work that we're now doing, and I think most of you are aware that the institutes at NIH are somewhat autonomous, and so some institutes have done more in this area than others, and we're really through this working group bringing them together and looking at ways that we, in our funding opportunity announcements, can have language to really encourage or request those more equitable partnerships, to ask specifically what is the role of the low and middle income country researcher in developing the research question or having access to data and writing papers. So this is something that's been a lot more attention to just in a few years, and we're starting with this bibliometric and fairly basic metrics. But it's something that's going to be developed further, that we are developing further in the months and years ahead.
Great, thank you. Another question more focused on the AAPS organization that has a lot of pharmaceutical organizations, private corporations. The question is, what are some exampple of the Fogarty facilitated collaborations with pharma in the low and middle income countries?
Yeah, that is a great question. So there is at the NIH more broadly, the Office of the Director and the other institutes have more of those kinds of collaborations. The AAPS, the Accelerated Medicine Partnerships, does include pharmaceutical companies, including global companies, including with the European Medicines Agency. So that certainly at NIH, there's a lot of those interactions and support. From Fogarty, we've been more focused on the training and capacity building. So we have some interactions around some of the genomic research with the private sector, but we're interacting with the academic institutions in the U.S. and around the world, or with the private funders, the Bill and Melinda Gates Foundation, the Wellcome Trust, or with ministries of health and ministries of science and technology in the countries where we work. So we're open to those interactions. It's just the kind of work that we're doing has been, relatively small money, relatively focused on the training and capacity building, and not on the kind of international pharma product development work.
Thank you. And picking up on the involvement of the non-governmental organizations, there's a question about what has been the impact of those non-governmental organizations like Bill and Melinda Gates Foundations on Fogarty's mission.
Yeah, well, we work closely. I mentioned Bill and Melinda Gates Foundation, the Wellcome Trust, another large philanthropic organization. We work with them closely. The Gates Foundation, we had Bill Gates come and speak at NIH about a decade ago, and since then we've had, it's now I think 14 working groups working on particular areas of point of care diagnostic tests, or tuberculosis, or maternal child health. And so those, I think 14, more than a dozen working groups are working year round on collaborations between the Gates Foundation and the NIH. And then we have an annual meeting where the principals come, Bill Gates comes, the NIH director, and convene these groups. So that's been actually a very productive interaction. And then one area where I've been working with them directly, we have something called the African Postdoctoral Training Initiative, where we identify 10 early career researchers from Africa. They come and they spend 2 years in an intramural laboratory at the NIH. And then with support from the Gates Foundation, they go back to their home Africa laboratory and have funding for 2 more years, salary support and research funding that's implemented by the African Academy of Sciences. So that's been a very rewarding and productive collaboration with the Gates Foundation that I've been closely involved with.
Excellent, thank you. One other question relates to the it's an operational question. The individual says, I'm not allowed to contract with some international institutions due to allegations of bribery and such. How does NIH navigate the international funding environment to ensure that funds reach the intended scientists?
Well, we have, pretty robust oversight of our funding, whether it's domestic or international, and that we require filing of financial reports and of how the funding has been expended and what actual progress has been made in the research. So it's not a particularly different set of activities around what's done internationally versus how that's overseen domestically. And I should point out that we do have funding directly to foreign institutions, but the vast majority, more than 90% of the NIH-supported international collaboration is we're funding a U.S. institution, and then they have a subaward with the foreign institution. And so the NIH oversight is directly over the primary grantee, the U.S. institution, and then they have their own ways of auditing or overseeing their foreign, whether it's a foreign or a domestic subawardee or collaborator.
Wonderful, thank you. There is a question about the courses that you talked. The question is, are there additional courses in development for other topics such as clinical formulation development and so on?
Oh, so NIH is a very big place with a lot going on. So if you look at those links, that was just out of a menu of about a dozen different courses. But if you dig around in there or just Google it, there's probably some resource, some training resource or information that would be of interest. And I should emphasize, if you want to find out more about cancer, contact the NCI, infectious diseases, contact NIAID. If you're not sure who you want to contact about global health, then come to Fogarty and we can help to orient you. But it's really, there's tens of thousands of people working at NIH in extramural programs, and their job is really to help fund researchers, to connect researchers to resources. So there's whatever your questions are, what you want to learn, there's probably a resource for you or someone who can help you.
Thank you. One question that we've always struggled at the AAPS global health community is to try and invite the low and middle income country investigators to attend meetings and conferences. So you talked a lot about investigator-focused research and funding. Are there funding opportunities through Fogarty International Center for travel awards or for attending conferences, short-term visiting fellowships, specifically for international scientists?
Yeah, so I did mention that we have the least funding of any institute or center at NIH, and we've really focused that on the research training and research. So there's a set of awards called the R13 that many institutes support for conferences and travel. And we generally from Fogarty do not have that kind of funding, just to really keep our limited resources focused on the training. Now, for the trainees, if someone's in one of our D43, HIV research training programs and is, getting an advanced degree with support from Fogarty, then they would have resources for travel to a meeting. But it's generally that kind of a situation, not just a freestanding travel award.
Thank you. There is one other question about just as a sort of a summary of your presentation. I think are there this question. What are the successful aspects of the NIH-funded collaborations in low-income countries like Uganda and Malawi and Ethiopia that should be noted by other low-income country investigators to obtain funding?
Yeah, that's a great question. And it is interesting, and a particular interest of mine, that we've really seen the emergence of some real centers of excellence, diamond level partners for NIH in South Africa, in Uganda, in Peru, where they have more than 100 NIH grants going on at any one time. And so, I mean, it's really, we're a science agency, we're a research agency, we're not a development agency. And so it really has to begin with the science and what are the particular research opportunities in that country, whether it's infectious diseases or genomics or some exposure or intervention that is going to be scientifically of interest to the NIH, to the review panels to get a good score to get funded. But then a big part of it is to actually have the research management capacity in tools to manage the funds appropriately for the human resources, the motor pool, the data, the laboratory, all of those aspects. And so it is very challenging. It's something I'm particularly interested in, is how we can work in countries where there's less infrastructure and to try to develop that, not as a development agency, but as a science agency where there's real scientific opportunities and research questions to be able to develop that. And then over time, and it's the same, it's a similar challenge in the US or high income countries, that you're just constantly getting one grant after the other to keep your enterprise going. And so that can be even more challenging in the lower income countries where people don't have dedicated research time, that they're very, their time is basically full with their teaching and their clinical activities. But we have seen many of these successful organizations develop, and that's our interest in developing more. So it's usually, if you're in an institution or a country that's never gotten an NIH award, I would not encourage you to apply directly. That the success rates are low and would be very low in that case. But to use a tool like World Report or just PubMed and see who are researchers that are working in your area that might be interested, and to find a researcher, usually a U.S. researcher, who's been successful in getting NIH funding, and say, look, I see you're working on, the microbiome in this country, and look, we've got this unique population and research opportunity to look at it in my institution in this country, and would you like to collaborate? And having them extend their research funding to work with you and your institution. That would be the approach that I would recommend.
Right. One other question. It's probably asking for the impact on the Fogarty International Institution. What has been the impact of COVID-19 global pandemic on government funding and prioritization for your organization? Specifically interested in if it is increased the awareness or global health, or has led to prioritization of local health systems at the expense of global health.
It's, I think it's been, obviously a terrible pandemic with many millions of deaths and a lot of disability. But I would even say it's one of the kind of silver linings is, if you ever needed to articulate why is it important to have global health research and global health partnerships, that COVID-19 was a really important example where a lot of the research and looking at the population impacts of therapeutics or vaccines, that we learned a lot from Israel and the UK and other countries, looking at positive examples for contact tracing and disease control. Really learned a lot globally. In terms of from Fogarty, we saw many of our former trainees and grantees really had lead roles, especially in the COVID-19 testing and genomic analysis. And so actually the individual who first characterized Omicron, Dr. Sikalili Moyo in Botswana, he was one of our former Fogarty, actually a current Fogarty trainee and grantee. And so, in terms of interest and awareness of the importance of global collaboration, that I would say was strengthened through COVID, despite the obviously negative health and social impacts. And so NIH budget has generally increased. We had an increase in our budget last year, especially for research on health disparities around the world. So in general, it's been a positive impact, I would say, in the recognition of the importance of global health research and collaboration.
Thank you. Thank you again for your elaborate presentation and excellent Q&A session. Before I pass it on to Chris Back, I just wanted to read a very heartfelt compliment from one of our attendees. Thank you for highlighting the value and quality of the research done globally, even in challenging resource environments. Work from South Africa was critical to the understanding of variants emergence and the association with chronically immunosuppressed populations, such as HIV positive populations. Yes. So I completely agree with that compliment. Thank you so much. And I'll, in the interest of time, pass it back to Chris Boyce.
Thank you, Pramod, and I'll pass it over to AAPS to wrap things up.
Thank you all so much for this wonderful presentation. For all of our folks who are online right now, this has been recorded and will be available on the AAPS website. Thank you all again, and we look forward to seeing you all at a future webinar. Have a great day.
Thank you very much. Bye-bye.